The silent killer, 7 early warning signs of stroke you can't ignore. The moment Sarah felt the left side of her face droop during her morning coffee, she knew something was terribly wrong. Just minutes earlier, she had been preparing breakfast for her children, feeling perfectly normal. Now, as she tried to call for help, her words came out slurred and incomprehensible. Her teenage daughter found her slumped against the kitchen counter, unable to lift her left arm. Within hours, Sarah would learn that she had survived a massive stroke that could have killed her. The difference between life and death came down to one crucial factor: her family recognized the warning signs and acted immediately. Every 40 seconds, someone in the United States has a stroke. Every 4 minutes, someone dies from one. These statistics represent more than numbers. They represent mothers, fathers, children, and friends whose lives are forever changed in an instant. Stroke remains the 5th leading cause of death in America and a leading cause of serious long-term disability. Yet despite its prevalence and devastating impact, many people cannot identify the early warning signs that could save their lives or the lives of their loved ones. The tragedy lies not just in the occurrence of strokes, but in the missed opportunities for prevention and early intervention. Research shows that up to 80% of strokes are preventable, and recognizing the warning signs can dramatically improve outcomes. When treated within the first 3 hours of symptom onset, stroke patients have significantly better chances of recovery with minimal or no disability. However, studies reveal that only about 38% of people are aware of all major stroke symptoms and know to call emergency services immediately. This knowledge gap costs lives daily. Unlike heart attacks, which often announce themselves with crushing chest pain, strokes can be deceptively subtle in their initial presentation. They earn their reputation as silent killers precisely because their symptoms can be mistaken for fatigue, stress, or minor ailments. People dismiss sudden headaches as tension, attribute speech difficulties to exhaustion, or explain away balance problems as clumsiness. These misinterpretations waste precious minutes when every second counts. Understanding stroke and its warning signs becomes even more critical when we consider the rising incidence among younger populations. While stroke risk increases with age, recent studies show alarming increases in stroke rates among people in their 30s and 40s. Lifestyle factors including obesity, diabetes, high blood pressure, and sedentary habits contribute to this disturbing trend. The COVID-19 pandemic has further complicated the landscape, with research linking the virus to increased stroke risk in some patients. The human brain requires a constant supply of oxygen and nutrients delivered through blood flow. When a stroke occurs, this vital supply is interrupted, causing brain cells to die within minutes. There are 2 main types of stroke: ischemic strokes, which account for about 87% of all strokes and occur when blood clots block arteries to the brain, and hemorrhagic strokes, which happen when blood vessels in the brain rupture and bleed. Both types can be devastating, but recognizing their warning signs offers the best chance for minimizing damage and preserving quality of life. The following 7 warning signs represent the most critical symptoms that demand immediate medical attention. Learning to recognize these signs could make the difference between full recovery and permanent disability, between maintaining independence and requiring lifelong care, between life and death. Each sign tells a story of disrupted brain function, and together they form a pattern that healthcare providers can quickly identify and treat. Understanding these symptoms empowers you to act decisively when every moment matters. Warning sign 1: sudden numbness or weakness. The human nervous system operates like an intricate electrical network, with the brain serving as the central command center. When stroke disrupts this network, one of the most common and recognizable symptoms is sudden numbness or weakness, particularly on one side of the body. This symptom occurs because strokes typically affect one hemisphere of the brain, which controls the opposite side of the body. If a stroke damages the right side of the brain, the left side of the body experiences symptoms, and vice versa. This numbness or weakness can manifest in various ways and degrees of severity. Some people describe it as a pins and needles sensation similar to when a limb falls asleep, while others experience complete paralysis. The onset is typically sudden and without warning. One moment, a person might be holding a cup of coffee, and the next moment, they cannot maintain their grip. The cup falls, not because of clumsiness, but because the brain can no longer send proper signals to the muscles. The face often shows the most visible signs of this symptom. Facial drooping on one side is a classic stroke indicator that even untrained observers can recognize. The affected side of the face may appear to sag, with the corner of the mouth turning downward. When asked to smile, the person cannot create a symmetrical expression. The eye on the affected side might also droop or fail to close completely. These facial changes occur because the facial nerve, which controls muscle movement in the face, is compromised by the stroke. Arm weakness presents another critical indicator that medical professionals use in rapid stroke assessment. The simple test involves asking the person to raise both arms and hold them at shoulder height for 10 seconds. If one arm drifts downward or cannot be raised at all, this suggests stroke. Some people describe the sensation as though their arm has become impossibly heavy or disconnected from their body. They might reach for objects and miss, or find that their hand cannot form a proper grip. Leg weakness can be particularly dangerous because it affects mobility and increases fall risk. People experiencing stroke-related leg weakness often describe a sudden inability to bear weight on one side. They might collapse without warning or find themselves unable to rise from a seated position. Walking becomes difficult or impossible, with the affected leg dragging or failing to respond to commands. This symptom can be especially frightening because it removes the ability to seek help independently. The distribution of numbness and weakness provides important clues about the location and severity of the stroke. Complete paralysis of one side of the body, known as hemiplegia, indicates a severe stroke affecting a large area of the brain. Partial weakness, called hemiparesis, might suggest a smaller stroke or one affecting specific brain regions. Some people experience numbness without weakness, while others have weakness without numbness. Both patterns warrant immediate medical attention. Healthcare providers use standardized assessments to evaluate numbness and weakness quickly. These tests measure strength, sensation, and coordination on both sides of the body. Even subtle differences between sides can indicate stroke. Patients might be asked to squeeze the examiner's fingers, push against resistance, or identify touch sensations with their eyes closed. These simple tests provide valuable information about stroke location and severity. The window for treating stroke-related numbness and weakness is narrow but critical. Clot-busting medications must be administered within specific time frames to be effective. For ischemic strokes, tissue plasminogen activator must be given within 4.5 hours of symptom onset. Mechanical thrombectomy, a procedure to physically remove blood clots, can be performed up to 24 hours after symptom onset in selected patients. The sooner treatment begins, the better the chances of reversing or minimizing permanent damage. Recovery from stroke-related numbness and weakness varies greatly among individuals. Some people regain full function within days or weeks, while others face long-term challenges. Physical therapy plays a crucial role in recovery, helping retrain the brain to control affected muscles. Occupational therapy addresses daily living activities, teaching adaptive techniques for dressing, eating, and other essential tasks. The brain's remarkable plasticity allows for significant recovery in many cases, but this requires intensive rehabilitation and patient determination. Understanding the mechanism behind numbness and weakness helps explain why rapid treatment is essential. When brain cells are deprived of oxygen, they begin dying within minutes. The longer the deprivation continues, the more extensive the damage becomes. Areas of the brain controlling movement and sensation are particularly vulnerable. However, surrounding brain tissue can sometimes compensate for damaged areas if blood flow is restored quickly enough. This concept, known as the ischemic penumbra, represents potentially salvageable brain tissue that drives the urgency of stroke treatment. Risk factors for experiencing stroke-related numbness and weakness include high blood pressure, diabetes, heart disease, smoking, and previous strokes or transient ischemic attacks. People with these risk factors should be especially vigilant about recognizing symptoms. Family members and caregivers of high-risk individuals should also learn these warning signs, as affected individuals might not recognize their own symptoms or be able to communicate effectively. The emotional impact of sudden numbness and weakness cannot be understated. People describe feelings of terror, confusion, and helplessness as their body stops responding to their commands. This psychological trauma can complicate recovery and requires attention alongside physical rehabilitation. Support groups, counseling, and family education help address these emotional challenges and improve overall outcomes. Warning sign 2: sudden confusion or trouble speaking. Language represents one of humanity's most complex cognitive achievements, requiring precise coordination between multiple brain regions. When stroke disrupts these language centers, the results can be immediately apparent and profoundly disturbing. Sudden confusion or trouble speaking often serves as one of the most recognizable stroke warning signs, affecting not just the ability to communicate but also the capacity to understand and process information. The brain's language centers primarily reside in the left hemisphere for most people. Broca's area, located in the frontal lobe, controls speech production and the ability to form words. Wernicke's area, found in the temporal lobe, manages language comprehension and the ability to understand spoken and written words. Connecting pathways between these regions coordinate the complex process of communication. When stroke damages any of these areas, various types of language difficulties emerge. Aphasia, the medical term for language impairment following stroke, affects approximately 1/3 of stroke survivors. This condition manifests in multiple forms, each presenting unique challenges. Expressive aphasia, also called Broca's aphasia, impairs the ability to speak while leaving comprehension relatively intact. People with this condition know what they want to say but cannot find or form the words. They might speak in short, fragmented phrases, omitting small words like is, and, or the. Their speech often sounds telegraphic, conveying meaning through content words alone. Receptive aphasia, or Wernicke's aphasia, presents an entirely different challenge. Affected individuals can speak fluently, but their words make little sense. They might use incorrect words, create nonsensical words, or string together properly formed sentences that convey no meaning. Simultaneously, they struggle to understand others' speech, creating a profound communication barrier. The frustration of being unable to understand or be understood can be overwhelming for both patients and their loved ones. Global aphasia represents the most severe form, combining elements of both expressive and receptive aphasia. People with global aphasia have extensive language impairment, affecting speaking, understanding, reading, and writing. They might only be able to produce a few recognizable words or sounds, and their comprehension is severely limited. This condition typically results from large strokes affecting multiple language areas of the brain. Beyond formal aphasia, stroke can cause various other communication difficulties. Dysarthria affects the muscles used for speech, resulting in slurred or slow speech that sounds drunk or tired. Unlike aphasia, dysarthria doesn't affect language comprehension or word-finding ability. Instead, the physical act of speaking becomes difficult due to weakness or paralysis of speech muscles. People with dysarthria know exactly what they want to say but struggle with articulation. Confusion represents another critical warning sign that might accompany or occur independently of speech problems. Stroke-related confusion can manifest as disorientation to time, place, or person. Affected individuals might not recognize familiar people, understand where they are, or remember recent events. They might ask repetitive questions, provide nonsensical answers, or appear to be living in a different time period. This confusion differs from normal forgetfulness in its sudden onset and severity. The sudden nature of these symptoms distinguishes stroke from other conditions causing gradual language decline. One moment, a person might be engaged in normal conversation, and within minutes, they cannot form coherent sentences or understand simple questions. Family members often describe the experience as watching someone they love become a stranger, unable to connect through the fundamental human tool of language. Healthcare providers use various rapid assessment tools to evaluate speech and language function during suspected stroke. The Cincinnati Pre-Hospital Stroke Scale includes having the person repeat a simple sentence like, "The sky is blue," or "The early bird catches the worm." Inability to repeat the phrase correctly, slurred speech, or using wrong words all suggest stroke. More comprehensive assessments examine multiple aspects of language function, including naming objects, following commands, reading, and writing. The location of brain damage determines the specific type and severity of language impairment. Strokes affecting the middle cerebral artery, which supplies blood to major language areas, commonly cause aphasia. Smaller strokes might produce more limited symptoms, such as difficulty finding specific words or mild confusion. Brain imaging helps identify affected areas and guides treatment decisions. Time remains the critical factor in treating stroke-related language problems. The same treatments that restore blood flow for other stroke symptoms can preserve language function if administered quickly. Thrombolytic therapy and mechanical thrombectomy have shown success in reversing or minimizing language impairment when provided within appropriate time windows. Every minute of delayed treatment increases the risk of permanent language disability. Recovery from stroke-related language problems requires intensive speech and language therapy. Speech-language pathologists work with patients to rebuild communication skills through various techniques. These might include repetition exercises, picture naming, reading practice, and conversation therapy. Technology increasingly plays a role, with tablet applications and computer programs supplementing traditional therapy approaches. Family involvement in therapy significantly improves outcomes, as loved ones learn to communicate effectively with the affected person. Alternative communication methods become essential for those with severe or persistent language impairment. These might include gesture systems, picture boards, or electronic communication devices. Learning to use these tools requires patience and practice from both the stroke survivor and their communication partners. Support groups specifically for people with aphasia provide valuable opportunities to practice communication in a supportive environment. The psychological impact of losing language abilities can be devastating. Language connects us to others, allows us to express needs and emotions, and maintains our sense of identity. Stroke survivors with language impairment often experience depression, anxiety, and social isolation. Addressing these emotional needs through counseling and support services is crucial for overall recovery. Prevention awareness becomes particularly important given the devastating impact of stroke on language function. Managing risk factors like high blood pressure, diabetes, and atrial fibrillation can significantly reduce stroke risk. For those who have experienced transient ischemic attacks or minor strokes, aggressive risk factor modification and preventive medications can help prevent future events that might cause permanent language impairment. Warning sign 3: Sudden trouble seeing. Vision, our dominant sense for navigating the world, relies on an intricate system extending from the eyes through the optic nerves to multiple brain regions. When stroke disrupts any part of this visual pathway, the results can be immediate and disorienting. Sudden vision problems serve as a critical stroke warning sign, one that people often initially attribute to less serious causes like fatigue or need for new glasses. Understanding how stroke affects vision and recognizing these changes can prompt the rapid medical intervention necessary to preserve sight and prevent further brain damage. The visual system's complexity makes it vulnerable to stroke at multiple points. The occipital lobe, located at the back of the brain, serves as the primary visual processing center. The temporal and parietal lobes contribute to visual interpretation and spatial awareness. Blood supply to these regions comes from the posterior cerebral arteries, and blockage or bleeding in these vessels commonly causes stroke-related vision problems. Additionally, strokes affecting the brainstem can damage nerve pathways controlling eye movement and coordination. Sudden vision loss in one or both eyes represents one of the most dramatic stroke-related visual symptoms. This loss might be complete, rendering the affected eye unable to perceive light, or partial, creating blind spots or areas of darkness within the visual field. Some people describe it as though a curtain has been pulled down over part or all of their vision. Unlike the gradual vision changes associated with conditions like cataracts or macular degeneration, stroke-related vision loss occurs within minutes or seconds. Double vision, medically termed diplopia, creates a particularly disorienting experience. Stroke can damage the nerves controlling eye muscles, preventing the eyes from moving in coordination. As a result, each eye sends a slightly different image to the brain, creating overlapping or side-by-side double images. People experiencing this symptom might close one eye to eliminate the double vision, tilt their head to compensate, or struggle with balance and coordination due to the confusing visual input. Visual field defects present another common manifestation of stroke affecting vision. Hemianopia, the loss of half the visual field, can occur when stroke damages the visual pathways. People with this condition cannot see anything to the right or left of center, depending on which side is affected. They might bump into doorframes, fail to notice people approaching from one side, or only eat food from half their plate. This symptom can be particularly dangerous when driving or navigating stairs. Blurred vision affects many stroke patients and can range from mild haziness to severe distortion. Unlike the blur from refractive errors that glasses can correct, stroke-related blur stems from disrupted neural processing. Objects might appear fuzzy, colors may seem washed out, or fine details become impossible to discern. Some people describe their vision as looking through frosted glass or heavy fog. Visual neglect represents a particularly puzzling symptom where the brain fails to process visual information from one side, despite the eyes functioning normally. People with visual neglect might only shave half their face, dress half their body, or draw only half of a clock face. They remain unaware of objects, people, or even their own body parts on the affected side. This condition differs from blindness because the eyes can see, but the brain cannot attend to or process the visual information. Stroke can also cause unusual visual phenomena such as hallucinations or distortions. Charles Bonnet syndrome, which can occur after stroke-related vision loss, causes vivid visual hallucinations of patterns, people, or objects that aren't present. Visual snow creates the perception of static or flickering dots across the visual field. These symptoms can be frightening and confusing, particularly when combined with other stroke effects. The sudden onset distinguishes stroke-related vision problems from other eye conditions. A person might be reading, driving, or watching television when their vision suddenly changes. Some describe the experience as switching off a light or having someone place a hand over their eye. This abrupt change, particularly when accompanied by other stroke symptoms, demands immediate medical attention. Emergency responders and healthcare providers use specific tests to quickly assess vision during suspected stroke. These might include checking pupil responses, testing peripheral vision, and evaluating eye movements. Simple bedside tests like counting fingers or identifying objects help determine the extent and nature of vision loss. More comprehensive testing in the hospital can map specific visual field defects and guide treatment. The window for treating stroke-related vision problems mirrors that for other stroke symptoms. Rapid intervention to restore blood flow can prevent permanent vision loss. Success stories include patients who regained full vision after receiving clot-busting medications or undergoing mechanical thrombectomy. However, delays in treatment increase the likelihood of permanent visual impairment. Recovery from stroke-related vision problems varies widely depending on the location and extent of brain damage. Some people experience spontaneous improvement within days or weeks as brain swelling decreases and alternate pathways develop. Others require extensive vision rehabilitation to adapt to permanent changes. Neurooptometrists and occupational therapists specializing in low vision work with patients to maximize remaining vision and develop compensatory strategies. Adaptive techniques help people cope with persistent vision problems after stroke. These might include using scanning patterns to compensate for visual field loss, employing high-contrast materials to improve visibility, or using prism glasses to address double vision. Environmental modifications such as improved lighting, removal of clutter, and use of contrasting colors enhance safety and independence. The impact of vision loss on daily life extends far beyond the immediate visual impairment. Reading, driving, recognizing faces, and enjoying visual media become challenging or impossible. Social isolation often follows as people struggle to navigate public spaces or participate in activities they once enjoyed. Depression and anxiety commonly accompany vision loss, requiring psychological support alongside vision rehabilitation. Technology increasingly offers solutions for stroke survivors with vision problems. Screen readers, magnification software, and voice-activated devices help maintain independence. GPS navigation aids compensate for spatial awareness difficulties. Virtual reality systems show promise for vision rehabilitation, helping retrain the brain to process visual information more effectively. Understanding risk factors for stroke-related vision problems emphasizes the importance of prevention. Conditions affecting blood vessels, including diabetes, high blood pressure, and atherosclerosis, increase stroke risk. Regular eye examinations can detect early signs of vascular problems. Managing these risk factors through medication, lifestyle changes, and regular monitoring reduces the likelihood of experiencing stroke-related vision loss. Warning sign 4: sudden trouble walking. The simple act of walking requires remarkable coordination between the brain, nervous system, and muscles throughout the body. When stroke disrupts this intricate system, the ability to walk can vanish within moments. Sudden trouble walking represents a critical stroke warning sign that manifests in various ways, from subtle balance problems to complete inability to stand. Understanding these mobility changes and their underlying causes can prompt the immediate medical attention necessary to prevent permanent disability and preserve independence. Walking involves multiple brain regions working in concert. The motor cortex initiates voluntary movement, the cerebellum coordinates balance and fine-tunes movements, and the brainstem controls automatic aspects of walking. Sensory systems provide feedback about body position and the environment. When stroke damages any of these components, different aspects of walking become impaired. The specific walking difficulties depend on which brain regions are affected and how severely. Ataxia, characterized by uncoordinated and clumsy movements, commonly results from strokes affecting the cerebellum or its connections. People with ataxia might walk with a wide-based gait, swaying from side to side as if intoxicated. Their movements appear jerky and poorly controlled. They might struggle to walk in a straight line or make precise movements like touching their nose with their finger. This lack of coordination affects not just walking but all voluntary movements. Balance problems present another common manifestation of stroke-related walking difficulties. The sense of balance relies on input from the inner ear, vision, and proprioception working together. Stroke can disrupt any of these systems or the brain's ability to integrate their signals. Affected individuals might feel as though the room is spinning, struggle to maintain upright posture, or fall repeatedly to one side. Some describe feeling as though they're on a boat in rough seas, unable to find stable footing. Hemiparesis, weakness on one side of the body, creates characteristic walking patterns in stroke survivors. The affected leg might drag behind, requiring extra effort to move forward. People often develop a circumduction gait, swinging the weak leg in a semicircle rather than lifting it normally. The foot might drop, catching on carpets or uneven surfaces. Upper body involvement adds complexity, with the affected arm held against the body and reduced arm swing disrupting natural walking rhythm. Sensory deficits compound walking difficulties after stroke. Loss of proprioception, the sense of body position, makes it difficult to know where limbs are without looking at them. People might stomp their feet while walking, seeking sensory feedback through impact. They struggle on uneven surfaces or in darkness when visual compensation isn't available. Some describe feeling as though they're walking on cotton or clouds, unable to feel solid ground beneath their feet. The sudden onset of walking problems distinguishes stroke from conditions causing gradual mobility decline. A person might rise from a chair and immediately collapse, their legs refusing to support their weight. Others notice problems when attempting to walk to the bathroom during the night, suddenly veering into walls or furniture. Some describe their first awareness coming when they try to step out of a car and their leg won't respond normally. This abrupt change from normal mobility to impairment signals the urgency of the situation. Fear often accompanies sudden walking difficulties. The loss of mobility threatens independence and triggers primal anxieties about falling and injury. This fear can create a vicious cycle, with anxiety about walking leading to muscle tension and further impairment. Some people become frozen with fear, unable to attempt movement even when physically capable. Addressing both the physical and psychological aspects of walking difficulties is crucial for recovery. Healthcare providers use standardized assessments to evaluate walking and balance during suspected stroke. The National Institutes of Health Stroke Scale includes tests of limb coordination and gait. More detailed assessments might involve timed walking tests, balance assessments, and evaluation of specific gait components. These tests help determine stroke severity and guide immediate treatment decisions. Brain imaging reveals the specific locations of stroke damage causing walking problems. Strokes in the motor cortex typically cause weakness-related walking difficulties. Cerebellar strokes produce coordination problems. Brainstem strokes can affect multiple aspects of movement and balance. Understanding the anatomical basis of walking problems helps predict recovery potential and guide rehabilitation approaches. Immediate medical intervention can prevent permanent walking impairment. The same time-sensitive treatments used for other stroke symptoms apply to mobility problems. Restoring blood flow through thrombolytic therapy or mechanical thrombectomy can reverse or minimize walking difficulties if provided within appropriate time windows. Every hour of delay reduces the likelihood of regaining normal mobility. Rehabilitation for stroke-related walking problems begins immediately and continues for months or years. Physical therapists work with patients to rebuild strength, coordination, and balance. Treatment might start with supported standing, progress to walking with assistive devices, and ultimately aim for independent mobility. Innovative approaches include treadmill training with body weight support, robotic-assisted walking devices, and virtual reality systems that gamify rehabilitation exercises. Assistive devices play crucial roles in maintaining mobility and preventing falls. Canes provide stability for those with mild balance problems or weakness. Walkers offer more support for those with greater impairment. Ankle-foot orthoses address foot drop, preventing tripping and improving gait efficiency. Wheelchairs ensure mobility for those unable to walk safely, maintaining independence and community participation. Home modifications enhance safety for stroke survivors with persistent walking difficulties. These might include installing grab bars, removing throw rugs, improving lighting, and creating clear pathways. Bathroom modifications such as shower seats and raised toilet seats address high-risk areas. These environmental changes reduce fall risk and support independent living. The psychological impact of losing walking ability extends beyond physical limitations. Walking represents freedom, independence, and adult capability. Suddenly requiring assistance for basic mobility can trigger depression, anxiety, and loss of self-esteem. Support groups, counseling, and peer mentoring help address these emotional challenges. Celebrating small improvements and focusing on achievable goals maintains motivation during the long recovery process. Falls represent a significant risk for stroke survivors with walking difficulties. Fear of falling can become as limiting as actual physical impairment. Fall prevention programs teach safe movement strategies, environmental awareness, and proper use of assistive devices. Building confidence through supervised practice reduces both fall risk and fear. Community reintegration challenges those with persistent walking problems. Navigating public spaces, accessing transportation, and participating in social activities become complex. Americans with Disabilities Act accommodations help, but many barriers remain. Advocacy for improved accessibility benefits not just stroke survivors but all people with mobility impairments. Recovery timelines vary dramatically among individuals. Some regain near-normal walking within weeks, while others face long-term limitations. Factors influencing recovery include stroke severity, age, pre-stroke fitness, and rehabilitation intensity. The brain's plasticity allows for continued improvement even years after stroke, encouraging persistent effort in rehabilitation. Prevention remains the best approach to avoiding stroke-related walking problems. Regular physical activity, blood pressure control, and management of other cardiovascular risk factors reduce stroke risk. For those who have experienced transient ischemic attacks or minor strokes, aggressive risk factor modification and preventive medications can prevent future events causing permanent mobility impairment. Warning sign 5: Sudden severe headache. Headaches plague millions of people daily, usually representing nothing more serious than stress, dehydration, or fatigue. However, when a headache strikes with sudden, overwhelming intensity unlike anything previously experienced, it may signal a life-threatening stroke. This distinctive headache, often described as the worst headache of one's life, serves as a critical warning sign that demands immediate medical attention. Understanding the characteristics that distinguish stroke-related headaches from routine headaches can mean the difference between prompt treatment and catastrophic outcomes. The mechanism behind stroke-related headaches varies depending on the type of stroke. Hemorrhagic strokes, where blood vessels rupture and bleed into or around the brain, commonly cause severe headaches. The sudden increase in pressure within the skull triggers intense pain. Blood irritates brain tissues and surrounding membranes, creating inflammation and further pain. Subarachnoid hemorrhages, bleeding in the space between the brain and its protective covering, produce particularly severe headaches that patients often describe as thunderclap headaches due to their explosive onset. Ischemic strokes, caused by blood clots blocking brain arteries, less commonly cause headaches but can still produce significant pain. Large vessel occlusions might trigger headaches through several mechanisms. The lack of blood flow can cause brain swelling, increasing intracranial pressure. Additionally, collateral blood vessels dilating to compensate for blocked arteries can trigger pain. Some ischemic strokes affecting specific brain regions like the cerebellum or brainstem are more likely to cause headaches. The quality of stroke-related headaches differs markedly from typical headaches. Patients consistently describe them using extreme language, explosive, excruciating, or like being hit with a baseball bat. The pain reaches maximum intensity within seconds to minutes, unlike tension headaches or even migraines that build gradually. This sudden onset, reaching peak intensity almost immediately, represents a red flag that healthcare providers recognize as potentially indicating stroke or other serious conditions. Location of pain provides additional clues about stroke-related headaches. While the pain might be generalized throughout the head, it often concentrates in specific areas related to the stroke location. Bleeding in the back of the brain might cause occipital headaches at the base of the skull. Some patients experience pain on one side of the head, corresponding to the side of brain affected. The pain might also radiate to the neck, particularly with subarachnoid hemorrhages. Associated symptoms accompanying stroke-related headaches help distinguish them from benign headaches. Nausea and vomiting occur frequently, often more severe than with typical migraines. Neck stiffness, particularly with subarachnoid hemorrhage, makes it painful or impossible to touch the chin to the chest. Sensitivity to light and sound intensifies beyond typical headache levels. Many patients also experience altered consciousness, ranging from mild confusion to complete loss of consciousness. The timing of stroke-related headaches often provides diagnostic clues. Many occur during physical exertion, emotional stress, or activities that raise blood pressure. Some patients report the headache beginning during sexual activity, straining during bowel movements, or heavy lifting. Others experience the onset during sudden position changes or after trauma. However, stroke-related headaches can also occur during rest or sleep, awakening patients with severe pain. Personal and family history influences the interpretation of sudden severe headaches. People with no history of headaches who suddenly experience severe head pain face higher stroke risk than those with established headache patterns. Family history of brain aneurysms or hemorrhagic strokes increases concern. Previous high blood pressure, especially if poorly controlled, raises red flags when combined with sudden severe headaches. The danger of dismissing severe headaches as just another headache cannot be overstated. Many stroke victims delay seeking help, taking over-the-counter pain medications and hoping the pain will pass. This delay can be fatal, particularly with hemorrhagic strokes where continued bleeding increases brain damage. Even when the initial bleed stops, risk of rebleeding remains high without medical intervention. Time lost to home treatment attempts can eliminate opportunities for life-saving interventions. Emergency medical evaluation of sudden severe headaches follows specific protocols. Healthcare providers quickly assess vital signs, looking for elevated blood pressure that might indicate hemorrhagic stroke. Neurological examinations check for other stroke signs including weakness, speech problems, or vision changes. The combination of sudden severe headache with any neurological symptom strongly suggests stroke. Diagnostic imaging plays a crucial role in evaluating stroke-related headaches. Computed tomography scans can quickly identify bleeding in or around the brain. For suspected subarachnoid hemorrhage, CT scans detect blood in over 95% of cases when performed within 24 hours. If CT results are negative but suspicion remains high, lumbar puncture might detect blood in cerebrospinal fluid. Magnetic resonance imaging provides detailed brain images and can identify ischemic strokes not visible on CT. Treatment for stroke-related headaches focuses on addressing the underlying cause rather than just pain relief. For hemorrhagic strokes, controlling blood pressure prevents further bleeding. Surgical interventions might be necessary to repair ruptured aneurysms or remove blood clots pressing on brain tissue. Medications to prevent vasospasm, a dangerous narrowing of brain arteries following subarachnoid hemorrhage, improve outcomes. Pain management, while important, remains secondary to treating the stroke itself. The prognosis for patients with stroke-related headaches varies depending on stroke type and treatment timing. Subarachnoid hemorrhages carry high mortality rates, with about one-third of patients dying before reaching the hospital. However, those who receive prompt treatment have significantly better outcomes. Advances in neurosurgical techniques and critical care have improved survival rates and reduced disability among those who reach specialized stroke centers quickly. Long-term consequences of ignoring severe headache warnings can be devastating. Survivors of untreated hemorrhagic strokes often face permanent disabilities including paralysis, speech problems, and cognitive impairment. Hydrocephalus, excess fluid accumulation in the brain, can develop after hemorrhagic strokes. Seizures affect many survivors. The financial and emotional toll on families caring for severely disabled stroke survivors underscores the importance of recognizing warning signs. Prevention strategies for stroke-related headaches focus on addressing modifiable risk factors. Blood pressure control remains paramount, as hypertension represents the leading risk factor for hemorrhagic stroke. Smoking cessation reduces aneurysm formation and rupture risk. Limiting alcohol consumption, managing stress, and avoiding stimulant drugs decrease hemorrhagic stroke risk. For those with family history of aneurysms, screening might identify problems before rupture occurs. Public education about thunderclap headaches and their potential significance could save countless lives. Many people remain unaware that sudden severe headaches might indicate stroke. Healthcare providers increasingly emphasize teaching patients to recognize dangerous headache patterns. Simple messages like "seek immediate help for the worst headache of your life" can prompt appropriate action. The role of bystanders in recognizing stroke-related headaches proves crucial. Family members, co-workers, and friends might witness someone experiencing sudden severe headaches and can advocate for immediate medical attention. Understanding that this symptom represents a medical emergency empowers bystanders to override the affected person's tendency to minimize symptoms or delay seeking help. Technological advances improve recognition and treatment of stroke-related headaches. Telemedicine allows rapid consultation with stroke specialists for patients in rural areas. Mobile stroke units bring CT scanning capabilities directly to patients, enabling faster diagnosis and treatment initiation. Smartphone apps help people recognize stroke symptoms and connect with emergency services. Research continues to improve understanding of stroke-related headaches. Studies investigate biomarkers that might predict aneurysm rupture risk. New imaging techniques better visualize small aneurysms and vascular malformations. Treatment innovations include less invasive surgical approaches and improved medications for preventing complications. These advances offer hope for better outcomes but cannot replace the fundamental importance of recognizing warning signs. The message remains clear: sudden severe headaches demand immediate medical evaluation. Unlike typical headaches that respond to rest and over-the-counter medications, stroke-related headaches represent medical emergencies requiring specialized care. Recognizing this distinction and acting promptly can prevent death and disability. When someone describes experiencing the worst headache of their life, believe them and act accordingly. Warning sign 6: sudden dizziness or loss of balance. The human balance system represents a marvel of biological engineering, seamlessly integrating inputs from the inner ear, eyes, muscles, and joints to maintain upright posture and coordinated movement. When stroke disrupts